All right. The doors are closing. Okay. So let me introduce my friend and colleague, Dr. Stephen Frick, who is the chairman of the Department of Orthopedic Surgery at Nemours Children's Hospital, and whom I've had a pleasure of working with over the past year since our new hospital opened. Steve is our leg man. He does our he does a lot of things, but when it comes to CMT, it's sort of all things in the lower extremities in particular. But we also focus on upper limbs and hands, and so you're going to hear from Steve today the orthopedic component and how he contributes to our clinic. Steve has been challenged by his height, and but he was able to get beyond that impairment by playing basketball at GW, and then went to medical school in his native South Carolina, and then proceeded through orthopedic training and pediatric orthopedics, and he's involved in several of the national societies for pediatric orthopedic research. And we're just really delighted to be able to work together and have Steve contribute to our CMT program. So before taking up too much more time, I think I'll let Steve talk and share with you some of his thoughts on pediatric CMT. Thank you, Steve.
Thanks. Thank you. Good morning. Welcome to Orlando. It's a beautiful day out there, so hopefully you get to enjoy some of Central Florida's weather. And for those of you that got a chance to see our hospital last night, we're proud of it and we're excited about what we're building here. And I'm excited to, one of the reasons I came here from Charlotte, North Carolina, where I'd practiced for 15 years, was to work with people like Richard Finkel, who really phenomenal world leader in understanding muscle and nerve diseases. And that's something that I've always been interested in. And CMT in particular, I'm interested in because, quite frankly, I don't really understand it all that well. Why do these things happen to children and adults for their musculoskeletal system? The things I'm interested in, so their backs, their hips, as we heard the question I walked in at the last panel, and then a lot of foot issues and hand issues. So I'm going to go over that a little bit and then hopefully have some time. I'm going to drink some coffee. I was on call last night and operated until late in the evening, or morning. I guess earlier this morning I was awake operating. So it's good to be with you. And if while I'm talking I say something that really gets you going, just raise your hand and we can have questions while I'm going. So I don't have any conflicts or financial issues. You guys know more about this than I do, and certainly Dr. Finkel does, but it is helpful when I've taught residents for my 15 years in Charlotte, and they need to know what CMT is and how it's classified, and how it's classified helps us for the type 1. It's really where the musculoskeletal problems are going to be, and primarily foot problems for type 1 patients. And then type 2 patients have a little bit different. They often have more weakness and more of a flail foot and a little bit of a different lower extremity pattern. The type 3 kids show up earlier. It's an infantile form, and they're often very weak, and so we have to help them more with bracing and physical therapy support. And then the other types, and each one has specific issues that we try to think about orthopedically. Here are the big orthopedic issues. For me, number one, part of it is probably because my research interests are in childhood foot disorders. So I see lots and lots of foot problems. And North Carolina had as you all know, genetic issues with CMT, and we had a lot of families with CMT in North Carolina. So I took care of both adults and children when I was in North Carolina. Here in Orlando, I'm not sure how. Eventually I might get to where I can take care of some adults, but right now our children's hospital is 18 and under by the founding charter of our hospital. So, and I actually missed that. I really enjoyed taking care of adults with CMT when I was in Charlotte. So the foot's by far the most common thing. Hand involvement is common. And the numbers that are in the orthopedic textbooks are 10, 10, and 10. I don't think that's really very well studied. And hand involvement in particular is more common I think, than 10%. I think the numbers for scoliosis and hip dysplasia are probably about right for the number of patients who have significant problems that might need to be treated. It probably is somewhere around 1 in 10. But as I would teach the residents, if you see a patient that has a motor and nerve problem, every time you examine them, you should look at their hands, their feet, their spine, and their hips. And there's certain things that we do to look for those problems. Occasionally, those things need surgery, and I'll talk to you a little bit about that. But the most important thing, for me and for any other physician taking care of patients is take a good history. How are you doing? What's bothering you? What are your issues? Do a good physical examination. And then take x-rays where they're indicated when we know that certain things happen with a certain frequency. So in my practice, every child that has Charcot-Marie-Tooth at some point is going to get an x-ray of their hips, even if they're not symptomatic, because the problem with hip dysplasia is silent. And so the kids don't complain of pain. They often don't limp from their hips. It can be difficult when they're limping because maybe they have bad feet to say, well, is a limp from their feet or is a limp from their hips? But in general, I heard Dr. Finkel, he gets an A for his orthopedic knowledge, say that it doesn't generally happen in babies. So hip dysplasia and Charcot-Marie-Tooth is not what we see in little babies. Every little baby that's born, pediatricians in North America are taught check their hips for instability, where the ball's going in and out of the socket, the hip's too loose. That's what we call typical congenital hip dysplasia, or now a better term, developmental hip dysplasia. In Charcot-Marie-Tooth, hip dysplasia develops over time and is probably related to weakness around the hip girdle musculature, leading to abnormal forces across the growing hip, leading to the hip not developing normally. And that's one thing that we don't understand very well, how that happens. But it clearly happens with greater frequency in children that have Charcot-Marie-Tooth get hip dysplasia than in children that don't have Charcot-Marie-Tooth. And this is what it looks like. So you all can see that, right? So I show these pictures and that looks pretty okay to me. To me, to an orthopedic surgeon, it looks bad because the ball is not covered well by the socket. So nothing's broken, everything's lined up pretty well, the limb lengths are pretty equal, but this is an abnormal hip that has the socket is too shallow and its slope goes uphill too much. So we in orthopedics draw some lines we love to draw lines and measure angles. And so this angle is too much. It should be about 40 degrees. And essentially this is a ball that over time is going to slide up out of the socket and get too much stress on a focal area of the hip and lead to hip arthritis and then lead to probably getting a hip replacement. So the question is, we don't have enough information to say that every time on this child with this x-ray who's going to be in my clinic, Monday morning. Because to fix this, there's no simple fix to make this better, to prevent the hip replacement. To go back to the question from the last session, something should be done to prevent this. Well, yes, when we're confident that we have a good solution that will prevent it, and the risks and the benefits are aligned appropriately. So the benefits of doing something to try and prevent hip arthritis are better rather than the risks. So we also get special x-rays. So if you get an x-ray of that same child from the side, you really see how shallow this socket is. The socket of the hip joint should go more than 50% over the front of the femoral head from this view. And so it's really an anteriorly deficient socket, and that leads to abnormal forces and can lead to early arthritis. It should look like that one on the right. But so we agree that looks abnormal. Well, how do we fix it? Well, this is how you fix it. And this is no small operation. This is 5 hours of surgery, cutting the pelvis all the way around the socket, rotating the socket so it better covers the bone. And there's lots of things around there that you're cutting, the sciatic nerve, the femoral artery, all of those things have been reported to be injured with this particular operation. And it doesn't make every hip better. Some people still have pain and some people still get early arthritis. So we are much, much better. Yes?
What is the recovery time for a surgery like that?
That surgery would, patient would be in the hospital for probably 2 nights, would be on crutches for 4 to 6 weeks. And in general, it would take about 3 months for that to heal to the point that they would be walking on it fully. And depending on how you do the surgery and what happens with the hip musculature, it probably would be 6 months before they're walking really well without any kind of assistive device. And then you have to figure out on top of that, well, how are they walking beforehand and what is their strength? So if you have a patient that you're doing this on that has CMT and already has some weakness, having them have a big surgery and then not move for, for 3 months often leads to further weakness and further problems. So it can be it might be a year. So it may be a year before you really get all the benefits of the surgery. But that's a good question. So that's hip dysplasia. The other thing that every child with CMT should be checked for is scoliosis. So a lot of people have heard about scoliosis, and a lot of people are afraid of scoliosis, but in general, mild scoliosis is really not a very big health hazard. Many people have mild curvature in their spine. It doesn't make your spine weak. It doesn't make you more likely to have paralysis or weakness. It's just a curve in your spine. But it can cause some problems, and it causes trunk shift, it causes lower shoulders, and this is the way you examine is just look at them from the back. Every child in an orthopedic exam who has CMT should be looked at from the back, and then they should do this test where they bend forward, and we look to see how much curvature there is, and then I'm going to show you what's called the Adams forward bend test. Often they have one side higher than the other. This girl has two curves, and so she's kind of balanced her trunk out. But these are the problems with scoliosis. Your trunk shift, your head's off to the side, and that can lead to muscle imbalance, muscle pains, but it's hard to tell. So many people have back pain. 80% of adults in the United States miss work at some point in their life because they have bad back pain. Does scoliosis increase your risk of back pain or not? We don't really know because everybody gets back pain at some point, but it kind of makes sense that if your back is out of balance, that some of your muscles are going to work harder, and balancing your spine might lead to lower back pain. This is the test that all of you can do on any of your family members. You can just look at them from the back, tell them to bend over and touch their toes, and if you see a big hump and it's rotated, that's a sign that they have a scoliosis, a curvature of their spine. Because although scoliosis is defined as a curve to the right or the left, it's really a rotational deformity, and so in addition to curving to the right or the left, the trunk twists. And it's that twist that's most important in terms of the deformity. It's the twist that's most important in terms of diagnosing it. So that's why we do this test. You bend forward, you'll see that their trunk is twisted, and one side is higher than the other one. If you see the twist, you get an x-ray. So just like I said, we don't always x-ray the children in the clinic with CMT, but they should get an exam, and if their trunk looks twisted, they should go get an x-ray. And this is what scoliosis looks like. This is old surgery for scoliosis, not very successful. Now we have very powerful instrumentation and very safe surgical techniques with monitoring of the spinal cord, and we can basically, instead of grabbing the spine at one area here and one area here and sort of stretching it apart, which doesn't correct the deformity well and is dangerous to your spinal cord and neural elements, now we can grab the spine at every level with a screw and put two rods in instead of one, and we can take a very crooked, stiff spine and make it really pretty straight. That's no little operation. So that's 4 to 8 hours of surgery, and that's usually 4 to 5 days in the hospital, and that's 3 to 6 months to heal. And again, every decision we make in medicine, there's risks and there's benefits, and what are the risks and what are the benefits, and when the benefits are way better than the risks, then maybe surgery is what you need. So that's scoliosis. This has been my interest in CMT, and is management of foot deformities and trying to understand them. And they typically, but not always, I was talking to one of the attendees last night, not every patient with CMT has a cavo varus foot. They can have foot deformities and foot problems that aren't cavo varus. And so just because you don't have a high arch doesn't mean you don't have CMT, and just because you have a high arch, it doesn't mean you have CMT. So if you do have the high arch, though, it's not a very accepting foot deformity. So what we call a cavo varus foot, a high arch, I'm going to talk to you, it disrupts what we call the tripod of the foot. It makes you walk on the outside of your foot, and it makes your foot rigid. And so if any of you have children that have CMT and they have a cavo varus foot and you have a 2-story house, you can tell when they're walking around upstairs because they can't walk softly. It sounds like you have an elephant in your house. And that's because the foot becomes very rigid and it doesn't accept shock absorber. A flat foot, which many of you may have heard of, lots and lots of people have flat feet. I see hundreds of children every year for flat foot complaints. Flat feet are normal. Flat feet are supple. Flat feet are very flexible. They take up shock absorption, which is one of the jobs of your foot. And so orthopedically, I really don't worry much about flat feet. I would much rather have patients that have flat feet than have a cavo varus high arch foot. And it's because of this. So when you walk on the outside of your foot, it's basically like walking on a peg. It doesn't accept any of the shock absorption that normally happens when you go heel-toe in normal gait. And that causes pain and problems. And if you get a really high arch foot, we don't have very good shoes to accommodate that deformity. So many of you in this room know what this looks like. And so this is a very typical Charcot-Marie-Tooth cavo varus foot. A very high arch, increased plantar flexion or pointing down of the first ray, which you can see I'm pushing up on it here, trying to see how flexible it is. Extreme tightness of the plantar fascia and the little muscles on the bottom of the foot. Clawing of the toes. And so this is a very typical foot deformity. And Dr. Finkel and some of the other physicians who are talking to you guys are helping us try to figure out why does this happen and what goes on. The intrinsic muscles of your foot has, just like your hand, has what we call intrinsic muscles. Those are muscles that originate and insert in the hand or in the foot. And in your hand, those muscles do this. They bend your fingers down at the knuckles, and they keep the joints in your fingers straight, so they do that. And so when those intrinsic muscles stop working, your hand starts to do that. It starts to claw, okay? And why the intrinsic muscles get weak first? Is it just because they're furthest away and the myelin isn't normal? And so those are questions for the smarter doctors that are talking to you, not the orthopedic surgeon. But that's what's interesting to me. I don't know why the intrinsics go first, and then the foot, the intrinsics, the tibialis anterior, and then the peroneus brevis get weak, and it's always on our board test as to what the order is, and that's usually the order they give. I'm not sure that that's actually the order, but those three muscle groups getting weak leads to a drop foot, to plantar flexion of the first ray and a high arch, and to clawing of your toes. Yeah, there's a question back there? Well, what happens, plantar fasciitis is very common. It's pain right there in your heel. It hurts the first step in the morning, feels like somebody stabbed you in the bottom of your foot. And having a high arch, it's not related, I don't think, to the neurological issues with CMT. It's related to the biomechanical issues that you get a high arch and this stuff gets tighter, so it's stretched more when you're walking on it. And I think that people with high arch feet do get more plantar fasciitis. But lots of people get plantar fasciitis, I had it for years. Relatively miserable when you do have it. So, but those structures are important, and I think that the plantar fascia and the ligaments, I don't think are the pathology here. The pathology is in the muscles and the nerves that then put the foot in a position where it doesn't get stretched, and those ligaments then get tight. But if, as a surgeon, I want to make this better, I have to take care of all those tight structures in addition to trying to balance the foot. So this is what I just talked to you about. You lose the intrinsics, tibialis anterior, and the peroneals. You get a cavo varus foot. When we treat this orthopedically, we have to look at how flexible the foot is. In general, cavo varus foot deformities and Charcot-Marie-Tooth foot deformities are driven by the forefoot and the midfoot. And the hind foot is just along for the ride. So the hind foot is your heel bone and your talus, your ankle joint. And so in young children, I almost always can operate just on the hind foot and the soft tissues, the tight structures, and I don't have to do the heel nearly as commonly as in adults. The hind foot's been following along for 20 years, and I usually have to do surgery on the hind foot and the calcaneus too, and I'll show you that. I think especially in kids, this is an important thing. The problem here is muscle balance, so the foot gets imbalanced. And so if you have an imbalanced foot, if you do surgery on it and you don't try to balance the muscles that are remaining that are working, it might just pull back into the same deformity. And by far, the biggest frustration I have with trying to operate on cavo varus feet and make them better is recurrent deformity. So trying to balance the foot is important. And the principle is if you have a muscle that's working well and it's pulling the foot in, don't let it keep pulling the foot in. Move it somewhere else where it can help pull the foot straight. And so that's what we mean by not wasting a motor. Don't waste a muscle. Someone I was talking to last night is on your board, and they were talking about was not a physician, was talking to doctors about different things and how they have to dumb it down so that the board member could understand it. And I say, that's what I feel like when I talk to Richard Finkel. I'm like, okay, bring it down here to this level that I can understand. So, but if you think about your foot, it's really not very hard what the job of your foot is. You need a stable platform to stand on, and you need to be able to get one foot in front of the other without dragging it or tripping over it, okay? And those two things. So when I teach the residents, the first part of a good orthopedic physical examination is you open the door and you go out in the hallway and say, walk up and walk down, and the kids are always embarrassed and they're holding their little gown and they're walking funny, and mom's always going, walk normal, whatever that is. I don't know what walk normal means. That's like I tell the mom, I say, okay, mom, breathe normally. What is that? So we don't think about walking just like we don't think about breathing. So all you moms who are telling your children to walk normal, stop it. But this is the problem with cavo varus feet. So it's not a stable platform to stand on. That bone, the big toe bone pointing down, makes the foot twist out to the side. You're basically walking on the outside of your foot. You're kind of rolling your ankle all the time. And so you don't have a stable platform to stand on. So that's problem number one. And that's because of this. It's called the tripod effect. So normally, and there's probably a couple little arrows here. I'll just click through that. So normally what happens when you stand on your foot is that the first metatarsal, the big toe bone, the fifth metatarsal, and the heel should hit the ground at the same time. If the big toe bone hits the ground first, it makes your heel twist out to the side, and you end up with a cavo varus foot. And so that's where I was telling you before, the forefoot, the front part of the foot, the metatarsals are driving what happens to the hind foot, the heel bone, and the heel bone's just along for the ride. So, and this is what it looks like when it gets really bad. This bone's been hitting the ground first, then the fifth toe bone hits, then the heel twists into what we call varus, meaning it points outward, and this foot is stuck like this. This is an adult from my practice in Charlotte, and this is a terrible foot to walk around on. Not a stable platform. To get this, you just walk on this. And so, you get a bad callus underneath the fifth metatarsal head. It hurts. You can get stress fractures there. I'll show you a picture of that. And so if you're in the office and you have and this is one of those things Dr. Finkel talked about, let the parents educate the doctors. If you have a good orthopedic surgeon and they're looking at a varus foot from the back, they're going to put this block under there. And basically what they're trying to do is make sure that the first bone doesn't hit the ground at the same time. So you put this underneath the fifth metatarsal, and so now the first metatarsal and the fifth metatarsal are going to hit the ground at the same time, and your tripod's not going to twist. And then you can look at the heel. And you can see in this patient's heel, my pointer has just decided to die. So if you put that block under there and the heel stays crooked, then we know that the heel is now stuck. So this heel is twisting out a little bit and it gets pretty straight. So this is probably a foot where I don't have to cut the bone of the heel bone, and I can just do surgery on the forefoot and lengthen the plantar fascia and the tight plantar structures and get away with less surgery for this patient. That's why we do it. So, and that's a good sign. So if your orthopedic surgeon says, let's get you to stand on it, they're not crazy, they're doing a good job. That's what they should be doing. You can get calluses everywhere. This one's under the first metatarsal head where that big toe bone's hitting the ground first. And there's some bones there called the sesamoids that can become painful. Claw toes are very common. They can become painful as your shoe wears on the top of the PIP joint of the toes. This is an example. If you walk on that outside of your foot long enough, you can get a stress fracture. So this is a stress fracture. If you get a stress fracture and you have a cavo varus foot and they put you in a cast and think it's going to get better without correcting your cavo varus foot, it's not going to get better. So you got to operate on the foot and correct the alignment, the biomechanics, or this stress fracture is just, you got to change the stress. So stress fractures show that things are bad. You can also get to where your ankle rolls out. Every time you're rolling all the time, you can stretch all these ligaments, and this is the peroneal tendons that help hold your ankle stable on the outside of your ankle. So it's common in adults to get peroneal tendon pathology in addition to the ankle sprains. So this is a very common position in shoes. You wear out the outside of your shoes. Often patients with CMT have to wear high-top shoes. This drop foot leads to the second problem, which is if you can't pull your foot up, that's where you can't clear your foot. So you drag your toes. She's got some little skin changes on her toes, and she's having difficulty clearing her foot. So not only does she have a bad platform to stand on, now she can't get one foot in front of the other. And those are the things that lead me. One of the questions someone asked last night is, well, when do you have surgery for CMT in your feet? Well, when your feet are bothering you enough that the benefits of surgery outweigh the risks, because there are risks and benefits. But if you have functional problems, you don't have stability and stance, you don't have clearance and swing, you can't manage that with an orthotic, then for me, that's when we start talking about, let's do a surgery, and what surgery should we do? So that drop foot, when she pulls this is the best she can do to sort of what we call dorsiflex, or pull her foot up. And you see what happens is, as this tendon right here is the tibialis anterior that gets weak, and as it gets weaker, it can't pull the foot all the way up. There's another tendon on the outside called the peroneus longus. Those two tendons are what we call antagonists. So this one's pulling it up. There's a tendon that inserts on the bottom of this bone pulling it down. This one's winning. So it's pulled this bone way down. Big toe bone hits the ground first. But when she tries to walk, and you can watch them if you watch them walk barefoot, when they're swinging their foot, their toes go way up in the air like this. And that's because those toe extensors are trying to help. They're trying to pull that foot up so they don't drag their foot, so they get clearance and swing. The problem with that is that since the intrinsics don't work to keep those toes flexed down at the knuckle joint, at the metatarsophalangeal joint, it leads to clawing of their toes. So the more that this tendon on the top pulls, the more this thing's going to bend and become clawed, and so you get in this vicious cycle. One of the things, I just show this again, so you have to look at kids. You can't, if the orthopedic surgeon never makes you walk, never makes you stand on your feet, they're not doing a good job. If the problem is foot deformity, you got to see them standing, you got to see them walking. We always get x-rays to assess the bony alignment. This, you can see, this patient has the hind foot is in a really bad position, has been falling along too long. This is unusual, actually, in CMT. Most CMT patients look more like this, where the heel bone's pretty normal, and the problem is this first metatarsal or big toe bone just goes straight down. That's the problem. You can actually get that same test. You can put the block on their foot to see if the foot lines up better. And again, this is helping us make decisions about where and what kind of surgery we might do to move that foot around. You see that without the block, this bone is way over here. When they stand on the block, that foot comes back into a more normal position. All right, so cave varus feet, they're stiff. Non-operative treatment, braces, shoe wear can be helpful, but it doesn't fix the problem. And this is often in North Carolina. I noticed there's some better looking shoes here. But I had a real challenge. You take a young teenage girl that paints her toenails like this, you tell her to wear that, not going to happen. Not going to happen. So, and they don't want to wear a brace. You know, teenagers do not want to be different. They don't want to wear a brace. And so that's the real issue. So often, you know, the inability to accept wearing a brace it can be an issue, and that's a complicated discussion. We have to have that, because I can't always guarantee you with the surgery that you're not going to need a brace for two things, right? For stability and stance and clearance and swing. I can't promise that to everybody. That certainly is my goal, but I may transfer a muscle. The tibialis posterior muscle, again, the smarter doctors in the room have to explain it to me, but it is preserved in CMT most of the time and seems to be one of the last muscles to get weak. So I use it a lot to transfer, to try and take advantage of that motor and prevent recurrent deformity. But that muscle can get CMT changes too. And if it gets weak, you get recurrent deformity, I might tell you have to wear a brace. So I can't always promise that you won't have to wear a brace. So these are things that are mainly directed at orthopedic surgeons, to have them know that the principles are deformity correction and muscle balance. And muscle, the main thing for orthopedic surgeons to know is that you can't do soft tissue only muscle surgery and correct fixed deformity most of the time. And you can never do a muscle tendon transfer and expect that that muscle is going to correct the deformity over time. So you got to correct the deformity first, and then you can do the muscle balancing, muscle tendon transfers. So often, and this is where, you know, this is the orthopedic part that comes from experience and knowledge and and is that you have to do all those tests, examine the foot, look at those x-rays, put the block under there, watch them walk, and figure out, do I have to do soft tissue? Do I need to cut the bones? We try not to fuse or do an arthrodesis of joints if we can avoid it. Very frequently, when people see that the toes hit the ground first, the simplest thing in orthopedics is to lengthen the Achilles tendon. It usually doesn't need to be lengthened in CMT. So it's probably the most common surgical error I see is that people go to someone and all they get done is an Achilles tendon lengthening, and they haven't fixed the toe going down and the high arch and all those things. And in really young kids, in my practice, sometimes I can just correct their deformity by putting a cast on and changing it every week or two for a while and stretching out the bones and the tissues. Muscle balancing, these are the principles. That if you have a muscle that quits working, you don't have spares. You have things that we can move around and use, but they're not designed to do the exact same thing, so it's always a little weaker. It really never is going to be completely normal when you have a tendon transfer. But if you have a muscle that's pulling the foot into deformity and you leave it there and don't do something about it after you correct the deformity, it's probably going to pull the foot right back into the same deformity. So you got to do something to those muscles to change the deforming forces, either lengthen the muscle or transfer it. And then I mentioned you can't just do transfers to. So this is what a CMT surgery looks like. We've cut the first metatarsal to line it up with the talus, and so we dorsiflexed it, had a stress fracture that was fixed over here, had a calcaneal osteotomy as an adult to move the heel back over underneath the tibia, and very typical series of operations. This is what your plantar fascia looks like if you've never seen it, this little white stuff right here. This is the heel, the foot's looking at you just like this. So this is the heel down here, the toes are up here. And I like to lengthen it through a transverse incision where I can see it all. There's some little nerves nearby, but there's lots of ways to lengthen the plantar fascia. It heals usually with a nice scar. If you make it in the front off the heel pad, it doesn't seem to hurt people. And I'm going to quickly go through, I've been talking for about 25 minutes or so. And just show you some pictures of what different surgeries look like and then have some questions. But the one principle, if you're standing, is that your heel bone should be underneath your leg bone. Okay? Again, this is orthopedic, so it's not rocket science. So some real simple concepts help us. If you're standing, your foot and your heel should be under your leg. Shouldn't be way to the inside or way to the outside. So one way you can do that is you can cut the heel bone and just shift it over. And the other way, you can cut it and bend it. So those are just examples of heel osteotomies. They usually do if you put them in right. So if you put them in right, where they're not going across the joint and they're not sticking out too far and they're not down here on the weight-bearing surface, but sometimes they bother people, and once the bone's healed, you can take them out. But elective removal of metal is not usually needed in orthopedics. If you have a rod, screw, plate that's in and is put in the right place and it's not hurting you, there's really no advantage to taking it out. This is that first metatarsal, so we cut that big toe bone and pull it up. That's a common surgery that we do. This we try to avoid. So this is a fusion. This is called triple arthrodesis. It used to be the most commonly done surgery for cavo-varus feet and CMT, where you fuse the talonavicular joint, the calcaneocuboid joint, and the subtalar joint or the talocalcaneal joint. So those are the three joints. You fuse all three of those. It's really bad because this can happen. It's a hard operation to get perfect. If you leave some of those muscles and they pull what's left into a little bit of malalignment, then it puts all the stress on your ankle joint. And so then this bone right here should be flat like this. So this is awful ankle arthritis. And this patient actually came to me and her foot's pointing straight down. She's a banker, and she was told she should have an amputation. And she didn't need that, but she did have an awful ankle joint, and so she actually got a fusion and put her foot back flat. Again, gave her a stable platform to stand on. And she's very happy, very happy. But she has a very stiff foot, and we call that a pan-talar fusion. That's not a very good operation to have. So we try not to do fusions if we can avoid it. In young patients, we can often just do soft tissue. So this is a young boy that had cavo-varus feet and had tendon transfers, so had plantar fascia lengthening, serial casting to correct his deformity, and then moved his tibialis posterior from the back of the leg through this incision to the front, and then pulled it down and sewed it in the top of his foot. So it's my timer telling me to quit talking. If you have this surgery in an older patient, it's a lot of surgery. And raise your hand if you have stubbed your toe ever in your life. Does it hurt? This is like stub your toe times 1,000,000. Okay, so this is 21 incisions to correct a bad Charcot-Marie-Tooth foot in a 20-year-old male, okay, who's having pain, who's dragging his foot, you know, and so this is pre and post surgery. So here, this heel's in a little bit of varus. This one now you can see is in valgus, the right alignment, but he's got, you can't see, but every toe now is straight, has an incision on it. We moved his tendon to the front. It's a lot of surgery. It looks like this in the OR. So we straighten all the toes and put wires in them. We fuse the big toe joint and move it to the first metatarsal to pull it up. We cut the first metatarsal. We lengthen the plantar fascia. This is a lot of surgery. And afterwards, it's just what it looked like healed. So these are the don't look if you don't like bloody pictures series. But this is what the soft tissue release to cut the plantar fascia. You can do it this way on the inside of the foot. There are lots of structures there that are important. This is where you go a little bit deeper. If you have a more rigid foot, you still don't always have to cut the bones just because you have rigid deformity, but you have to do more soft tissue lengthening and lengthen all the little intrinsic muscles on the bottom of the foot, and even open up the talonavicular joint. I think this part's really important. So where you cut, here's the big toe bone. So if you can get enough correction through this bone that's behind the first metatarsal, they do better because the second metatarsal doesn't get as much stress if you cut the bone back here. So one of the complications of cutting the first metatarsal is you just move the stress over to the second metatarsal and they get a stress fracture. So I try to do the osteotomy there if I can do it to correct it. Sometimes you get a really bad deformity that's, you know, a 25-year-old, the feet have been like this a long time. There's no way that you're not going to correct this without taking out big chunks of bone like this and then straightening that forefoot. But if you can do that, that's better than and I think, so fusions aren't always fusions. So I told you before, we don't like to do triple arthrodesis fusions. That's these big joints right here and at the ankle joint and here. Little joints in the foot and the toe joints, you can fuse them. They don't take up a lot of stress. And so if you fuse them, you're not going to have a lot of stress transfer to the other joints. And then here's just what tendon transfers look like. Tendons are these white things that are attached to the muscles, and you can take tendons that are doing something bad and move them to somewhere where they will help. And that's really the principles of tendon transfers. There's lots of different tendons that we move around in Charcot-Marie-Tooth patients. And here's before and after. So here's a varus foot walking on the outside, now has a straight, the heel's now underneath the tibia. You know, here you can see some of the scars along the medial foot. The high arch on this side, you can see. And so we want the foot to be flat, be underneath the leg, and you can see the scars from the tendon transfers. It's not little surgery to have a Charcot-Marie-Tooth foot reconstruction. So foot deformities are common. They're related to this progressive muscle weakness and loss of the muscle, quote, what we call the balance around the foot. They're often progressive and disabling. You know, it's a stiff foot to walk on, it hurts, you get calluses and stress fractures. If it is really symptomatic and shoe wear, braces, cushions don't help, then I think surgery can be helpful. But every foot is different, and so you really need careful analysis of what. It's not one operation. It's not like you have hip arthritis, you get a total hip. You have knee arthritis, you get a total knee. It's not like that at all. Cavovarus feet are complicated, and every operation needs to get individualized for the specific patient's issues. So with that, I will. My email's there. If anybody has any questions, I left some cards on that table. I am on call, and I have to go back to the ER after I finish this talk, and so I don't know if hopefully I'll make it back for lunch, but if I don't, you're welcome to email me any questions, and again, my card's out there as well. So thanks for your attention, and I'll take some questions.
So we only have time for maybe one or two questions. Okay, I see a hand here. Anybody else raising their hand? Okay, I have one up here.
Doctor, I've had many surgeries like triple arthrodesis, Jones tendon transfer and such as a child and as an adult. I've never found any, let alone any other specialist, any orthopedic doctor who would say they would take CMT into account when they're doing the surgery. What you're saying about muscle balance and transfers, they claim they do whatever procedure they do, and they don't even research CMT. And they say they know it, but they show that they don't. Now, how can you convince them, I'm considering a surgery now, And when I asked I'm not going to use him now, but when I asked the doctor, would you please have your staff research CMT and see if it makes a difference in the procedure you're proposing, and he said angrily, no, I won't. So what can I do to convince a doctor to really understand this and see if there's any differences than if it was a normal
Well, I think
patient?
that,
I don't need
I don't know.
just a pointer.
Physicians go through a lot of education and get a lot of training and do all that, and then sometimes I think leads them to think that because they've done all that, that someone else might not have a better idea. And so it's not uncommon, especially for surgeons, to this is how I handled this problem. And I think it's about education and educating physicians, and to some degree you might be able to help educate them, but it sounds to me like you have someone that sort of thinks that they know it and they don't want to be educated. And I really don't know how to handle that problem from a patient's perspective. As an educator, yeah, I mean, he said get a different doctor. So, but I think you can. I think the issues are, for me, are really about, I don't know how to change CMT yet. I don't know how to change what we call the natural history, is what happens with Charcot-Marie-Tooth patients as they get older, to their muscle function, to their musculoskeletal alignment. And so taking that into consideration when you do the surgeries, I think, is important. So if you have a really strong deforming muscle, I'm not going to leave that muscle alone and just correct your foot. I'm going to do something with that muscle to make it not a deforming force and hopefully help me prevent relapse of the deformity. That principle is not something that, I hope that all the residents that I've taught about CMT understand that, but a lot of surgeons may not know that. Someone had a question in the back? Yes? Okay.
I think as a support group leader, the question I hear the most and read online the most is, when do I have my first surgery? And I think it's something parents deal with. The complication rate for surgery seems to be pretty high for our population. Do you find that to be true, or is it just more anecdotal? And what can we do to decrease our infection risk and things like that? Thank you.
Sure. Well, I think the infection risk should really be pretty low. I mean, I think that wound healing problems, which are not the same as infection, may be higher because we're cutting tight things and then stretching them. So you're stretching all these incisions. And so I think wound healing problems get better. They just take a little bit of time, and wounds will heal. Even awful, terrible looking wounds with time will fill in and heal. I think the biggest complications I see are recurrent deformity or failure to get all the correction that we want to get in surgery. And let me tell you, I mean, it's heartbreaking for parents. It's heartbreaking for the surgeon. I hate when my patients don't do well after I put them through a big surgery. And so I always tell them, I'm not telling you you're going to have one surgery. You're going to have one surgery. I'm going to do my very best to make it perfect, but there's a good chance that either it won't be perfect and we need a tune-up surgery, or that your disease is going to get worse and this is going to come back earlier than we would like for it to come back, and I might have to do something a few years down the road. But I think again, it's about education, and I'm trying to understand and it's different for every patient. You can't move the tibialis posterior to the front of the foot on a patient who can't actively move their foot in before surgery so just to do that, because a book says do this for CMT, that's the problem. So you have to individualize the surgery to every patient.
Dr. Frick, could you give us your email again?
Oh, sure. It's just Stephen with a V, .frick, F-R-I-C-K, @nemours.org.
So if you have any other questions,
and there's
please.
I left a bunch of cards on the table out there, too.
And will you be back for a lunch with the experts?
Depends on how the ER goes.
Okay, we hope so.
I will try.
We hope you. Thank you for such a wonderful talk.
Thank you.
Okay, we're going to get moving because otherwise Elizabeth might kill us. This is David Meisner, and I'm Sean McHale. We're part of the Charcot-Marie-Tooth Association Advisory Board. And really what that means to you as patients is not necessarily that you need to come and see us to make your braces, although that we do that and we are orthotists, but that we're a source for you if you do have a question in regards to bracing. Get on our CMTA forum and ask your question so other people can see it and share it as well. And we'll talk a little bit more about that. So we're both going to introduce ourselves and why we're involved with the CMTA. We're going to talk about some of the common presentations, although Dr. Frick just went through some of that, so I can breeze by that today. And then I'm going to discuss some of the various orthotic designs that we do use, and there's certainly nothing saying these are the only designs we ever fit patients with CMT, but just some of the clinical experiences we've had and share what works and what doesn't work for patients with CMT. So my name's Sean. I started out as an athletic trainer at Purdue, and I thought I was going to become a physical therapist. I worked in a physical therapy clinic, and I hated it. So I told one of my professors at Purdue, I think I'm going to go learn how to make furniture because that's what my grandfather did, and I wanted to work more with my hands. He said, well, why don't you think about becoming an orthotist? And I said, sure, what the hell is that? And luckily, it was like I got to describe a profession of helping people and working with my hands, and it actually existed. So I went and worked for a company in Michigan, and they sent me back to Northwestern, and there I am as a student about 11 years ago at the top of RIC in downtown Chicago, looking over Lake Michigan, learning orthotics. And when I got sent back to Michigan, I worked and did my residency there, and eventually I got put down in one of the hardest offices that they had, which was the Rehab Institute of Michigan. And I had the pleasure of meeting Dr. Michael Schei and getting involved with the Charcot-Marie-Tooth Clinic. And it was really fun and exhilarating. We were seeing patients from around the world, and we were seeing 10 people with CMT every week. And that's how I've been involved and stay involved with CMT. Because of that, we went through a big progression in what we were doing with the braces, and that's part of what I'm going to share with you. I left Detroit because of many reasons, but I now am a partner in a practice that's based out of South Bend, Indiana, and I opened an office up in Chicago for them. Part of what we do is, besides being in our clinics, we go on the road. So I got that company vehicle of my dreams, which is a mobile lab. Not the car I thought I was going to be driving around. But what this allows me to do is to go to schools with kids with disabilities and go to physical therapy clinics and not have to take someone's brace away from them, but to be able to work on it on their spot. And I do home visits and then besides being in my clinic and office. And we use a lot of technology. That's me, if you can't tell. That's a digital scan of my face. So, it's really what attracted me to leave Detroit, but obviously the hardest part of that was leaving the CMT clinic. I didn't know Dr. Schei was going to leave Detroit as well, but I left prior to him leaving, and it certainly was difficult for me, but I've been happy to stay involved with the CMTA. Want to go, Dave?
And I'm David Meisner. I guess my history is in some ways similar to Sean's in that I have an interest in building things, building furniture, and I found that my undergraduate degree, which was in human kinetics, I wanted to blend the two. And for some reason, I somehow stumbled into the industry of orthotics and prosthetics, and that pun is intended, as you saw me enter the stage tonight. So I do have CMT, and my legs are not quite as attractive as Pat, so I'm going to sort of save you the showing of my legs. But what actually got me more involved into the CMT community is not only just being an individual with CMT and a large family with CMT, but becoming a father with a child with CMT, and that's myself and my boy, Ethan. Ethan's at the back of the room. He's actually supposed to be at Walt Disney today, but wouldn't you believe that he had a temperature last night? And so he, I think, is enjoying his iPad just as much as Disney. So that's the future of children. So I think for most of this presentation, Sean's going to carry it through because we do have limited time. I'll be available throughout the weekend here and available for questions at the end.
So these hands and feet should look familiar, right? Yeah, we've seen them before. Yeah, well, they're actually someone we know in the room, right? Can't mistake the bracelets. But there are reasons for that, and Dr. Frink went through this somewhat, so I'm not going to belabor some of the the reasons, but there is a certain sequence to that. And one of the key messages I think David and I both kind of feel passionate about is getting involved early when that sequence is first starting with some kind of level of orthotic. Because the better we can manage alignment at the start of things, the more braceable you continue to be. And perhaps we can avoid some of those surgical procedures. Now, not to say that happens every time, because the neurology and the events that occur from the changes in the disease are going to still preclude, that management for certain people. But if you're not twisting your ankle or dealing with a sprained ankle, if we can do something to control some of your side-to-side ankle motion and that instability at a lower level, by the time you do need a higher level orthotic, you're going to be much more braceable. You're going to be much more tolerant of that higher level orthotic. So if you are someone with a younger child, that's certainly something to think about. And then there's that specific intrinsic changes that are occurring, and he went through this whole tripod effect as well, but you could kind of see this as a classic picture of what that trifecta effect means. So when that first ray is hitting the ground, how the, I had a pointer, how the, that affects that heel into a varus or a C curve kind of shape from the posterior. So in static weight bearing, that rigid plantar flex first ray is causing this increased varus or lateral turn. And in the real world, and not just pictures, they can look like this, right? So typically when we're looking posteriorly, we want to see a pretty vertical heel, and you actually want to see the lateral toes. You want to see the fourth and fifth toe. So when you're seeing the medial toes, you're not seeing the right toes, right? So biomechanically, we have issues now, and this is why we call this a triplanar deformity. So we're not just dealing with how you lift up and put down your foot, which is the sagittal plane. We're dealing with the side-to-side motion of the ankle, so the coronal plane, as well as the transverse plane. And that's where material selection and orthotic design, when we're thinking about it, what a triplanar deformity really means to us as orthotists is, why are we doing these things out of carbon fiber? Why are we having plastic AFOs break on us? It's because of all the pressures and movements in those other planes of motion. So that is part of the reason we've progressed in terms of our orthotic decision making. And we look at that foot from the front then, and you can kind of appreciate that C shape again. But the non-weight bearing position is pretty important for us as well. And this is something that, when we look at this foot and I'm trying to rebalance this foot and get good positioning, this open chain position is telling me if I'm trying to keep that foot in a straight position below the leg like this is really telling me what it's going to take to balance that foot into alignment. So the real confusing part here for orthotists and orthopedists and podiatrists is that some people will call this an accommodation and other people call it a functional correction. And I think that's dangerous because to me, an accommodation is really, you're taking the foot and you're not trying to move it. But they're saying, well, the deformity happens, so we're accommodating the deformity. So that's why some people will refer to this as an accommodation instead of a functional correction. And I think it's very important to say, no, we're trying to get correction. We're trying to get that foot back to where it's meant to be. We're trying to increase the straightness of these planes of motion. So to me, this is telling me I need to put a lateral wedge underneath this foot, which may be where this person has a very large callus, right? How many people want a lot of pressure underneath your calluses? Not at all. You don't think, because it seems counterintuitive. But actually, if I can do this and I can place that wedge laterally, then that first ray doesn't have to seek the ground as much. So when you're standing and you're standing lateral on your foot and your first ray is seeking the ground so much, that's what's causing this instability and causing that first ray to have to go down even further. And if I can bring that lateral wedge up to the foot and bring the ground up to the foot, that disperses the pressure all along the foot, and then also the first ray doesn't have to travel down. Guess what happens here? People feel better pressure distribution. So they're not just feeling that pressure on the outside of the foot, but it gets dispersed across the foot. And then that first ray also doesn't have to drop as far now, so then they don't develop the callus in that spot either. Does that make sense? Makes sense now that you've seen it, but it is very somewhat counterintuitive. And he showed the lateral block test, and all we've done here is taken a block and cut out the first ray, and you can see how that increased the verticality of the heel position then. And here's another example. So I think this was the same patient. I was showing you that foot in a non-weight bearing position. So again, too many toes on the inside, that C curve at the heel. You can look at the pressure mapping here, right? Big callus under here. And I'm going to put a wedge that's the thickest underneath the front part of the foot. That's very important in the orthotic designs. Here's an example of a person who had a very expensive AFO who didn't like wearing it. Had it for about 2 months, felt great for 2 months, then all of a sudden was intolerable, couldn't wear it. I put that much material, hardly anything inside there. Guess what it did? It rebalanced, redistributed the pressure. They can wear their brace again. It's a very important step in aligning the foot and improving that verticality of the ankle. Here's another patient we saw in clinic who had complaint of pressure, so they went to their local orthotist, and what did the local orthotist do? I'll take care of your pressure. I'll cut a hole, which worked for a few weeks. But eventually that foot sank deeper into the hole, and then the person had more pain. And the deformity maybe even got a little bit worse because we didn't redistribute that pressure across the forefoot. So what did I do? I filled the hole back in with a firm material, and I wedged across from lateral to medial, and all of a sudden we had much better pressure. The other thing that happens with that block test, and I kind of went quickly over it because I'm talking quickly, but one thing that I do when I do that with patients and someone who can't stand still and close their eyes, you put those lateral wedges under the heels and do that same close your eyes test, and it's amazing the difference that makes. If we have time at the end and we get a volunteer, we can try that too. It's pretty exciting stuff. So the normal center of gravity passing through the foot, everybody kind of lands on the lateral portion of their heel, and then you should see this nice sinusoidal wave, and the pressure distribution should come through the first ray. But in the typical CMT cavus foot, you're going to have more of a center of gravity mass like that, which is also why we end up with displacement, why our center of mass has to go so far laterally, and then we end up eventually with a waddle, right? You see that sometimes, and that's why our hip muscles are turning on and off inappropriately, and we end up getting some weakness because of how we're transferring our center of mass. So sometimes if we want to avoid some of those proximal changes, meaning the muscles above our knee, it's also why we need to work better on balancing these feet. So here's an example of that quality of base of support, how we're transferring that weight laterally across the foot. And here as the center of gravity passes over that base, it will track laterally and off the base of the fifth metatarsal. So what's that amount to as well in practical senses? It means shorter step lengths. It means increased inversion or toeing in when we walk. So those are all things, even before the weakness happens, it's just the poor alignment. Again, more evidence. And what are we seeing? Large callousing, so in that non-weight bearing position. The other really important thing to us as orthotists is our evaluation process. And when we're trying to make bracing decisions, we really need to understand the individual that we're making those decisions with. And obviously we want that input from the person. We want the knowledge of what they do through their daily living. Are there complaints that they're weak and they're stubbing their toes? Are they unstable and that's causing them to be tired throughout the day? Are they tripping and falling frequently, which is causing other injuries? Are they not doing things? And CMT is sometimes, because of its chronic nature, sometimes we just stop walking the dog as much, or we're not walking around the grocery store, or we forgot that one item at the grocery and we're already back at the front of it. So should I go to the back of the grocery store to pick up those eggs I didn't get in my cart? Depends if your wife's like mine or not, but you make that decision. But sometimes if you had the appropriate brace, or you had a brace that's a tool for you to use, maybe you would be able to make increased activity level choices in your lifestyle as well. So the other thing that has come up on the listserv is I have all these cramping pains at night, which they relate to the symptoms of the CMT, but it could also be related to the biomechanics related to the CMT. And if you address your biomechanics in a better way, then maybe some of those physical symptoms you're also dealing with at night. Oh, I skipped ahead. Those physical symptoms you're dealing with at night also could be improved because you've handled the biomechanics in a better way. So ask, explain, discuss, agree. Okay, so these are very important follow-throughs, and make sure you understand, well, why are you making those decisions that you're making? What are we doing with my foot that's going to be different in this brace compared to what has been done? Because if you're dealing with issues and they're not solving your problem, then we need to try to figure a better solution, and following the status quo is not necessarily going to do it just because it's a new brace. So, things to think about. Traditional orthotic goals are, prevent deformity, so we don't want to injure that ankle again, support and align skeletal structures, limit or enhance the motion about a specific joint. And then balance is particularly important, especially for people with CMT. You should be able to stand up and close your eyes. You should be able to put your feet in front of each other in your braces. And if you're not doing that, then maybe you need to have a little tweaking or tuning towards that brace. And that's something I do with every one of my patients. You put your braces on, you stand up. First thing I want you to do, even before you walk, is close your eyes. Does that feel different to you? Accident. Yeah, right. So treatment options are significant. We have many, many tools in our toolbox as orthotists. And really determining what the patient's goals are very important, considering the level of gadget tolerances on there. So is this going to be able to be put on by the individual? Are they going to, is it something that will stay in the shoe, or do they have to put it on their leg first? Do you put the buckle on the outside of the brace or on the inside of the brace? There's so many options, but really as a clinician, you have to consider all of those things before you make your final prescription or recommendation and come to an agreement. So this is a common foot orthotic we might make for someone with CMT. Again, you can see that very significant lateral forefoot post. The hindfoot's very neutral. And this is where I'm bringing up that question again. Will we really consider this a functional correction versus an accommodation? I've always considered it a functional correction. I think it's important for your orthotist to say, well, if you're not accommodating my foot, what are you doing with my foot? And do you have to accommodate my foot? Because is there any ability to get some level of correction is really how I would approach that question with my orthotist. Because for most part, yes, there is some ability, even in patients who've had arthrodesis procedures, that you have some ability to move that foot in towards a line of correction is important to that individual in terms of balancing and distributing that pressure. This is a design, this is called an SMO, which stands for supramalleolar orthotic. It's considered in the AFO family because it affects both the ankle and the foot, and it goes above the malleoli, which is a fancy word for your ankle bones. And they can be designed differently to either prevent pronation or prevent supination. So pronation, rolling your ankle inward, supination outward. Sometimes patients with CMT when we're real young will present as overpronators, even though as they grow older they will become supinators. Part of that has to do with the muscle tone, because the electrical signal to the muscles is lower. They have lower muscle tone, so they may collapse more towards an end range position. And to not terribly disagree with the orthopedist, although it's maybe not an orthopedic concern, for a functional purpose, it may affect issues like running and jumping. For example, this patient that I saw at my office last month, who was a significant overpronator and at the age of 5 still not having the ability to jump, has trouble then out on the playground and structures. And you can see he's rolling his ankles in and he's got that valgus presentation, or more of an L shape instead of a C shape here at the heel. And we put that compressive orthotic around his foot, and we're maintaining some stability. Well, functionally, the important things that are happening is he's now running and jumping better. So he was running before, but his arms were out here, which we call a guarded position. So like a tightrope walker who puts their arms out for balance, he was running more like that. He was always a little slower than the other kids, having difficulty with jumping, and immediately had significant changes. And you look, his base of support's really narrow. He's got a more vertical position of his heel. The alignment of his foot below his knee is much better. I forgot to take pictures when he was in my office. The father was very nice to send me pictures this week when I was realizing I didn't have any. Even though I've done tons of these for kids, you forget to pull out the camera sometime. But it was very nice of him to see this. Now, his father has CMT and has a progressive supinated arched foot, and maybe at some stage I will be dealing with that for this child as well, but currently his need is to protect against that, so functionally he starts developing better muscle movements and better habits so that down the road he has some of those skills developed, but also we're protecting the joint from stretching out the ligaments too. So because part of the issue when a child stands in significant overpronation is what they're doing to that medial ligament capsule as they stretch to an in-range position. So when I first got to Detroit, we were fitting a lot of rigid system double action ankle joints, and one of my first goals there was to try to decrease the weight on some of those designs. What we liked about this design was it provided a lot of torsional control, so you couldn't really twist it. And it provided a lot of coronal stability because we could do strapping on the inside around the foot, and it wouldn't really change shape very well. Where a lot of plastic orthotics, when you twist them and turn them, you can still twist the foot underneath it. It also was progressive in the sense that we could change whether we needed a spring in that joint or the angle of the pin. So by adjusting the pin, I could help somebody so that they hit that and then took off at a better angle. So this was one of the first designs we were really using in Detroit, and really it worked well and it didn't break quite as frequently, and we had good stability, but one of the issues was weight for patients, and sometimes the springs inside would break down and they'd come back and I'd get like 20 little pieces of coil, which we'd have to replace, but it didn't mean the whole brace meant to be replaced, so it was a good solution for a lot of patients. But as things progressed and technology in the field for us progressed as well, so did our solutions that we had to offer for people. We knew for a long time that patients would walk really well in toe-off product, but we also knew that when we were putting them on patients, they were likely to break them pretty quickly. So we were somewhat avoidant of these off-the-shelf carbon fiber AFOs at first, but as toe-off and Allard produced the Blue Rocker, it was a more rigid brace. It broke less often. It gave better stability. It was a good solution for a lot of people with CMT. We could manage the side-to-side mechanics of the foot with the shoe insert, and then when they weren't wearing the brace, they could still wear that shoe insert. So we like the modularity of the bracing system as well too. And maybe for somebody who's not necessarily needing an AFO full time, but could benefit from it some of the time, it was also a benefit to you as well. So we did like it for that purpose, and there was really some good research into the angle that this tibial shank was made in, so it helped mimic a lot of natural gait. When you stepped on it, the heel portion of the brace bends a little bit, and what that does is it mimics natural gait, where the first portion of gait is your heel acts as a cushioning or decelerates your foot to the ground. So because of the carbon fiber, what it does is it creates that deceleration of your foot to the ground. And then when you stand over the brace, and what your foot and ankle should do is provide a stable, balanced surface, it did that. And by being in the front of the leg, it helped provide some knee stability as well. And then as you rolled off the toe, it helped create that spring or toe-off mechanism that helps to accelerate your foot forward, so your hip then swings forward as well. So that's the biomechanics of this device, and we know that a lot of people with CMT do walk very well with that. there are a lot of other off-the-shelf carbon fiber braces that are out there, and to some extent not as well researched and not as dynamic. So for that reason, we have, like the Allard product, it's not to say every CMT patient needs that brace, but it has been a good solution for a lot of CMT patients. And one of the nice things is it's off the shelf, so you can go trial it and see if it is a good solution for you. And sometimes for those patients who are on the verge of needing an AFO, it's a good way to experience what an AFO might do for you in your life, and to get a sense for what that really means to you. And then you can think, oh, okay, an AFO might actually help me. It's a good idea that I do get a prescription for one. So the one thing about that, though, is every time I put a pair of blue rockers on a patient with CMT, I've always asked them, stand up. Okay, now sit back down. Stand up again. Because I find that the experience of doing that really changes your center of mass and your idea of balance. So it does take a little bit of getting used to. So don't get frustrated with that the very moment you would try something like this. For some patients, this wasn't a good solution because I forgot my sample of this. Wasn't a good solution because, you can hand me the Autobach one. It wasn't a good solution because the strut was on the lateral side of the foot, and that would hit the very prominent bone that a lot of people with CMT have, or the arch was so high that it would hit the upright. So even though we liked the mechanics, some people were just precluded because of their arch shape. They now do make a custom version of that brace as well. So your orthotist can take a cast of your leg, and they can make a a custom toe-off or blue rocker with a specific stiffness that you need as a patient as well. This company is based out of Rhode Island, Custom Composite, and what this allowed us to do at the clinic was make a similar brace with similar dynamics to the toe-off that the strut I could put on the medial side of the foot instead of the lateral side of the foot. Recently, Autobach has come out with an off-the-shelf brace that has a very similar profile, a medial. They've put this fancy Z in there, which they believe will cause energy to be stored in the strut and to create an articulation at the point of the ankle axis. So there's a lot of math that went into the construction of this, all to create a more realistic movement pattern at your individual's ankle. I haven't fit those on a lot of patients with CMT, but I'm looking forward to it. It just was released, it's like September, I think. So sometimes we put a brace, and I don't have an example of this either, that doesn't really restrict the ankle from going down at all, but all it does is act as a spring to the foot. For these patients, they're generally pretty strong still, so they can push their ankle down, they can lift it up, but sometimes their balance is really off and they have poor proprioception. So when the doctor would do the test to, can you feel me moving your big toe up or down, they wouldn't pass that. And sometimes, okay, let me move your ankle up or down, and they wouldn't pass that either. They couldn't tell if my ankle's being lifted up or being pointed down. So their proprioception, or their understanding of where their foot is in space, was very off. So by just doing a brace that came up the back of the leg and brought some sensation to the back of the calf muscle, all of a sudden we could restore some balance for those individuals. This is a smaller population of people with CMT, but there is a certain group of patients that did benefit from that. How I kind of relate that to my personal life is if I've been drinking a little too much and the room is spinning and I hold on to the wall, the room stops spinning. So to some extent, by bringing that pressure up to an area where the body has better sensation and better input, we're increasing then that awareness of where that foot is in space. Okay? So that's the reason we might use what is considered a dorsiflexion assist style AFO. The one on the left has two metal rods. They make that version with both the rods just on one side as well versus both medially and laterally. Some of my issues with using this particular brace on people has been, squeezes around the ankle bones, and I think the company who designed it realized that, so they started putting both rods just on one side, which is nice. You can also incorporate a foot orthotic inside of that as well. And then this is obviously a plastic version where it would be molded to a patient's leg, and then these joints are kind of pre-bent forward. So when you're standing on them, they wouldn't be pushing your foot up, but when you lift your foot off the ground, there's some elevation or lift up or kick up of your foot. So I was interested, though, at several conferences we went to for orthotics. The Canadians, who had less access to carbon fibers, decided to work on a project called the ESR, and that stands for Energy Storage and Return. So I went up to Canada, and I met the guys who designed this style, and what they made this brace. This one actually fits my leg, and if I jumped on it, you would see my leg actually comes up. It bounces much higher than the other leg, but it's 3 layers of plastic, and you can come and see this thing. It's heavy, it's bulky, but what's cool about it is when you load the strut, it bounces back. So that's your energy storage and return. So it's using the same physics or principles of those running legs that like the Olympic athletes are running on, those prosthetic running legs. It's using the same physics in that it's flat, and it creates then movement just in this plane of motion. So typically we hadn't had a lot of orthotic solutions like that. The problem for manufacturing with this in the United States is it's time intensive, and if the modification's not done absolutely perfect around the heel, you get a lot of heel pressure. So I liked the dynamics and the idea of this, and that's where I started to discover and learn more about the fat braces, which came out of Des Moines, Iowa by a company called Biomechanical Composites. And what you'll notice here is the shape is very similar in terms of the flatness. He's done some research in terms of this sinusoidal wave so that, again, the articulation or the bending moment concurs with where your ankle would access. So they diverge in a kind of theoretical space. But basically, when you bend it, again, you get that energy return. And there's various stiffnesses of the strut. One of the issues with this is it is somewhat rigid to put on initially, but in time, this area that's all glass around the foot becomes very soft. It becomes sock-like, but it takes some time to break in that glue that initially is bonding this glass that surrounds the prepreg. This is a very strong carbon version of a brace because unlike other carbon braces, which are usually made in ovens or high temperature ovens, this is done in I think autoclave kind of process where they actually turn it into a liquid and then bring it back to a solid. For that purpose, there's no way to really rush making these braces, but what it does mean is they're going to stand up to a lot more stress that you put on them. The other issue is you get a lot more dynamics in the sense that the lever arm of the dynamic strut is much greater than some of the other off-the-shelf AFOs, which the dynamics occur more at the foot plate and rather than throughout the entire strut. Kinetic Research is another company that I've gotten more recently involved with. They particularly had made a product called the Noodle. Now everything they make is called the Noodle. And it's about patient selection and figuring out the right dynamics for the patient you're involved with. Often we'll still make a custom orthotic that fits on top of this. The question is how much control, how much stability do we need for the individual? What strength of strut do we really need to select for that person? So I wish to say that we always got those decisions right, but that's a challenge, and it's really hard to necessarily predict that. And you can go in the front or the back of the leg. This design he really likes for CMT patients because it's going to give a little bit more stability. It's got this arm that comes down on the outside of the leg, and what that does is for that ankle that wants to roll outward, you're putting the pressure then above the ankle bone on your tibia, which is a pretty pressure tolerant area, and gives you basically like a hand holding your leg to prevent that ankle from rolling outward. So, and that's called the valga noodle, which is over there on the outside. They can all be made with different stiffnesses, different strut strengths, but are generally best done to a cast. He does provide some off-the-shelf versions of these, so you can trial them, but again, it's about picking the right match for the right patient, for the right design that fits. What we like about carbon fibers that I didn't really emphasize earlier is we get a lot of bending in the plane of motion we want based on how the braiding and the layup of the material is done. But what we don't get is a lot of transverse rotation, so it's hard to rotate that foot underneath the strut, and you don't get a lot of coronal plane mobility then either. Admittedly, we don't have a lot of capture over the heel in a version like this, but that's where a custom foot orthotic can provide some of that correction to that side-to-side position. Probably feels a little more comfortable than standing on this plate anyway. So, and plus it allows you to wear that orthotic when you're not wearing the rest of your brace, which maybe you want to do sometime. So, in a practical sense. The silicone AFOs is something David's worn personally, and you know, I've used some. Sometimes it's the issue of funding, which is somewhat of an issue. Certainly, in terms of comfort, it can be more comfortable, and because it's a softer material, it's going to allow for more give. But you have a trade-off there in terms of your ability to create corrections as well.
Yeah, I can speak a little bit to, I think a lot of what we've shown here for bracing is, like a key point is we're showing a lot of devices here, and there is not any one device that's going to be perfect for you. You might find that multiple devices are what's going to achieve everything that you want to do in life, and that's essentially what I am doing. These silicone braces work very well. They allow full range of motion. They allow me to go swimming. I'll put on a pair of Crocs. I can walk in and around the beach. I can walk into a pool. But if I want to go golfing, a lot of times I will use a carbon system. I've tried a lot of these myself, and there's positives and negatives to each of them. And you know, what's great about all of these presentations is you guys are starting to learn to be advocates for yourselves, try to learn some of the biomechanics behind it, maybe bring some of these points to your orthotist, and to have something built that works for you.
Something I wanted to mention today, just because it's a general usual question when we're in these groups, is how about these E-stem units? And there's different names: the BioNest, the WalkAid. So these systems work by stimulating the nerve with an electrical signal, and one physician mentioned it earlier too. It doesn't seem to do that much. Well, it can when there's still some myelination and still good nerve signaling. But the issue is, if there's demyelination, then the electrical signal still won't stimulate properly. And we've had patients go to other offices. The companies actually say they're contraindicated for people with peripheral neuropathies. But that doesn't mean there aren't orthotists out there who are trying to sell this as a solution and say, come and try this sort of thing. And we have had patients come back and say, you know what, I tried it really hurt me too. So, you know, in general, just know that the companies who manufacture say peripheral neuropathies contraindicated. So something you're aware of because it will be marketed to you. So, conclusion, and David mentioned this as well, there isn't really any one solution for each individual. And there may be multiple braces that would fit your lifestyle. And unfortunately, our system may not pay for that, but you know, you have to figure out what's most important to you in terms of going back to how are these tools really going to be used in your life. The right solution may take some tweaking and adjusting. So, you know, there's a lot of unforeseen things. We've been talking about internally, you know, when do we use this design, and when do we use that, and how come, you know, we can see two patients that will present the same way and it works great for one and doesn't work great for another. And that's the reality of, you know, we're complex people who have a lot going on with us, and the presentations are complex as well too. So be your own best patient advocate. Talk to your orthotist. Make sure that if you go home and you put your brace inside of a drawer, don't do that. Go back to your orthotist, really explain to them, this isn't working for me. Can we find another solution? Can you help me in a different way? And an orthotic is a tool for you. Use how you wish it. It doesn't hurt my feelings that Susan Rudiger, every time I see her, is not wearing her braces. But last night when I sat down and had dinner with her, she told me the story that, what was it, 7 years ago that we first met, and I was sitting in a hotel lobby in Atlanta waiting for her to pick me up to take me to her support group to talk to them. And she came in the lobby, and before she could even say something, I said, "Hello, Susan." And she said, "Why? How do you know I'm Susan?" And she didn't know I'd been stalking her, but I could tell because of how she was walking towards me. And I pushed her into getting something and doing something. And you know what? It's perfectly fine for me that she uses them when she needs to use them. But last night she looked at me and she said, "You've really improved my quality of life by making me do something about it." So it's a tool for her. She uses it when she needs to use it. But I'm sorry I picked on you, Susan, but I figured you wouldn't mind. But at the same time, it's helped her and it's improved her quality of life. So think about that in your own world. What tools do you have? So, and then this is my child and David's 2 kids. So, thank you.
Thank you, David and Sean. I don't think we have time for questions because it's time for
4 minutes
lunch.
early.
However, if you do have questions, you could sit at either David's table or Sean's table at the lunch with the experts. So for right now, we're going to go to lunch. Could I let you know that if you have any problems getting your food and bringing it to the table, please let me know. Please let Gina know or another member of the CMTA, Susan, back there, who's just there. We're here to help you out with the buffet, so please just flag us down. Please enjoy your lunch, and we'll see you back here in an hour and 15 minutes.
Rachel Barron, how are you?
Thank you.